Thanks, Randy and Foundation, for having me and for letting me participate in this project. We're going to present all the surgeons are going to present a handful of cases. I think some of them are very straightforward things that we see on a routine basis in spine surgery, and some are, I guess, a little bit more complicated, but still things that we're seeing in spine surgery. And I think that the idea here is let's talk about what we would ordinarily do, and let's talk about where vertebral body osteotomy may have a role either now or in the future, and what we need to do to, really get us there. So this is a patient who comes to my office. He's a 53-year-old male. He's not a smoker. He has hypertension. It's under control. He had an L4-S1 fusion about 10 years ago and did excellent. Coming now with progressive worsening neurogenic claudication and a bit of an L3 radiculopathy. He's done all the appropriate conservative care options and he's interested in surgical strategies. He's got a normal physical examination in terms of his neurologic status. His BMI is 32. You can see on the X-ray he's had this prior fusion surgery, and I mean, there's really is good solid fusion here. He has degenerative changes at L3-4, slight retrolisthesis. The foramen appears collapsed. We have no gross instability really on flexion or extension. Maybe a millimeter on flexion, but I think that's even pushing it. So no movement and no coronal plane deformity. He's got a little bit of facet subluxation from the retro, but again, no gross instability. He's got cystic change in the disc. He's got some in the end plate. He's got vacuum disc phenomenon. His instrumentation is solid. His MRI shows, at least moderate, but approaching severe central canal stenosis and foraminal stenosis at L3-4, with some modic changes in the end plates. So I think depending on the symptoms, I think all of us might approach this in a handful of different ways. I mean, I think in some scenarios, some of us would say straight laminectomy with foraminotomy, depending upon how confident you are, you can get the foramen open with foraminotomy. I said that this patient has really neurogenic claudication, but the presence or absence of back pain and the severity or degree of that would probably impact us too, as far as pursuing some degree of fusion. But in the absence of back pain, would we want to proceed with fusion? And is intrabody osteotomy an option here? Is intrabody osteotomy where we, instead of raising disc height, if we lengthen the height of the vertebral body, can we achieve the same sort of indirect decompression? I'm not sure we know that. It may be something that we need to do in the lab. I'd be curious to know what people are thinking about in terms of sort of a standard adjacent segment degeneration case like this.
Ed, I mean, if this patient had some collapse, but not this significant retrolisthesis and didn't have much back pain, and you were just concerned about the foramen, might that tilt you more toward a vertebral body osteotomy versus, an indirect decompression by jacking up the disc space? So I guess you spoke to these things, is it back pain? Is it a translational instability? Uh, how would you go about it and sort of develop your own algorithm of how you might consider VBO?
Yeah, I think the cleanest, simplest indication is to your point, something where the alignment is pristine, foraminal height is compromised, central canal is really not, and you just need to obtain sort of a vertical decompression of the foramen. That's the cleanest, simplest indication, and again, in the absence of back pain. But the opportunity, I think, is there for a patient like this who has, yeah, there is retrolisthesis, but I don't see it as frankly unstable. I mean, if you look at the facets here, they don't look particularly problematic. He doesn't have a lot of facet disease. He has normal facet fluid signals. Um, I wonder if, when we do interbody fusions and we do indirect decompression, we're relying on ligamentataxis of the posterior annulus as well as the ligamentum flavum. If we went through the body, you're not going to change the posterior annulus through ligamentataxis, but is the dorsal ligamentous tensioning, is that adequate? I think it'd be interesting to do that in the lab, Randy, by the way. and get post-op MRIs. Does anybody think it'd be insane to do an osteotomy on a case like this?
This is Raj. Can you hear me?
Yeah.
Yeah, I think Baron's point is a very good one, which is the retrolisthesis here is a little bit worrisome, right? Retrolisthesis, facet disease, and back pain, which may not improve with a vertebral body osteotomy. But I think that your points are well taken. That if you've got really good alignment and you just need femoral height, that would be a better indication than this case, which on your X-rays, you've got a fair bit of retrolisthesis here, which tells you that there is, going to be some component of instability here.
Ed, do you have a CAT scan? Did you show a CAT scan?
Yeah, let me go back. Those are the cuts I have.
Yeah, I think, when you alluded to this one too, when you have some vacuum disc phenomenal, there is some macromotion here, yeah?
Yeah.
So that can explain that retrolisthesis. So, I think the motion preserving device will do better, with those osteotomy if the disc space is pretty healthy. When I see this with the vacuum disc phenomena, with this retrolisthesis, with this, the space between those facets, I'm more inclined to, to fuse that patient.
Agree with you, Puya. For the sake of time, and thanks, Raj, as well for your comments, we should probably get to the next case.
Yeah, there is a question in the comments that we want to save that for the end. It's a good question.
No, go ahead. Go ahead and take that right now.
Is the vertebral body osteotomy going to further accelerate the adjacent segment disease by worsening the pressure and stress at the adjacent segment? I'm assuming the adjacent segment disc. So I'm not sure that we know that yet. I mean, with interbody fusions, we know that increased intradiscal pressure occurs, but that's really because the disc spaces below or above have been locked, right? So motion is now occurring through those discs. Does just increasing the height of the vertebral body increase intradiscal pressure? It may. I mean, logically, it would make sense. Does it do so to the magnitude that you would have the risk or the same risk of adjacent segment disease as you would have with a fusion? I don't think we know that yet.
Good answer. We should probably go to the next case.
Agreed. Thank you.